My talk is mainly about the case selection. What patients are the right patients to do in the OS, Outpatient Interventional Suite, which is probably the most important thing to do, because if your patients end up in the emergency room after your procedure, or there is a complication which you have to send it to the emergency room, the amount of time you spend and the paperwork you go through and the reputation damage which happens is big time, because once they end up in the emergency room, that local area hospital is going to keep on back timing you, and it's going to say this patient came from that OBL, so they're going to do a lot of things. These things happen all the time. No matter how careful you are, complications happen. No matter how good you are, they happen. You just have to pick and choose your cases so that you can minimize it. All right, can we go to the next slide, please? I can, right? So, so just appropriately screening the patients, especially for peripheral interventions, because that's where you actually see most of the complications, right? And for dialysis patients, of course, the complication rates are very minimal, but you just have to be careful about how to do it. Venous insufficiency patients have the lowest complication rates. You just have to be pick and choosy and not to be too aggressive with the venous cases, and then you can get away with a lot of complications very easily. Um Type of patient to avoid. When somebody is, usually when people come and ask me, what kind of patient, which patient should you avoid doing in OBL? I usually say any patient can be done in OBL. It depends on you, right? How aggressive you are, can you manage the complications or not? That depends on it. But I think when you start off, you have to be very safe, because you want a very good reputation in the community. It spreads very quickly. You just have to be very careful about it. Remember, you can always do complicated cases in the hospital. Nobody's pushing you to do things in the outpatient lab. Patient safety is the most important thing. Um, and the type of patient to avoid usually is obese patients, elderly patients above, because they are the ones who actually have very frail vessels. ESRD patients on hemodialysis, because there are a lot of calcification, so they actually have the most amount of complications. Just like any other patients you see as high risk. If somebody has cardiomyopathy, severe COPD, prior CVAs, because any anesthesia you give, preferably everything should be done under local. But again, if you give any anesthesia for any reason, you don't want them to get complicated, because again, it becomes reportable. So anesthesia dependent patients, definitely not, because they're going to keep on fidgeting on the table, and you don't have that much staff as you have in the hospital where you can call for a backup. So there is no reason to deal with a patient who is going to be very fidgety on the table. Prior surgical complications, if they has, don't repeat the same mistake. Acute limb ischemias, of course, should be avoided in the OBL 100%, because they have to stay overnight. Kidney transplant patient, usually kidney transplant patients are avoided in the OBL. The reason being, transplant is a very expensive procedure. You don't want to be any reason for that transplant to fail, because it's inexcusable. So, type of lesions to avoid is iodoiliac lesions. If they're calcified and chronic total occlusions, can you do it? Yes. I think everybody who's coming to this conference who's very well versed in endovascular can do these cases. It's not about can you do it. The question is, should you do it? I think you should not do it. It's just because of the risk of PERS and everything, and we don't watch the patients overnight. Patients go home. So it's patient safety again. It comes back to patient safety. Is it necessary to do it? Severely calcified lesions, of course, should be avoided. Risk of perforation, the same way. Aneurysmal diseases definitely should be avoided if possible, because most of the aneurysms have layered thrombus in them. So the more amount of manipulation you do in the thrombus, in the aneurysmal disease, you can have peripheral embolization, number one. Number two is risk of perf. Tortuosity and iodoiliac tortuosity. Now, in this day and age, I think we can go away by doing these cases in the OR, because you can get radial, you can actually go with pedals, but again, you have to pick and choose the patients you do. Iontofemoral graft cases, definitely try to avoid them as much as possible, because of the risk when the sheet goes through the graft, there is risk of thrombus. Again, you can go from pedal and do the case, but most of these patients who have iontofemoral grafts, that means they have a lot of peripheral artery disease. So you sticking those pedal vessels is probably not the right thing to do. So you might want to do it in the hospital, only because you want to watch them overnight. You just want it to be safe for the patients. Fem bypass cases, yes, because the risk of bleeding is less. You might end up sticking the graft, which is not necessary to do. Can you do it? Yes. Should you do it is the question. AAA repair cases, again, difficulty. Remember, it's not only about patient complications, it's also about time. The amount of time you're going to spend in the OBL, is it worth it? So the first one is basically the tortuosity along with calcification and aneurysm. So it's this case is going to be difficult to cross over. Again, you can do pedal, yes, but depends on the number of pedal vessels you have. I don't do that many pedals in the OR. I train in Sinai, so I'm a big proponent of femoral access. Radial access, yes, I can consider it, but pedals, I usually try to avoid pedals. I feel like pedals should be reserved only when it's necessary to be stuck. Primary pedal interventions, I'm not a big fan of it. So a lot of people do it. I don't know if it's right or wrong. I think it's okay. It depends how comfortable you are, how successful you are with it is most important thing. Again, calcification, try to avoid it as much as possible. You can do it in the hospital very safely. Remember, it's all about staffing, right? It's about backup. You have a lot more backup in the hospital than you have in the OBLs. And you have vascular surgery, you have anybody to come and help you out if something goes wrong. So again, if you have total occlusions, definitely, especially iliac occlusions, definitely try to avoid it. SFAs, you can go for it. That's absolutely fine. Again, graft cases, definitely try to avoid it because just getting over them. Again, even if you go from radial, putting the sheets through these graft cases, there's no reason to, because these cases are very tough to do. They are done in the hospital. Somebody has done it a really good job. You putting a sheet through this is not necessary because you can always get antegrade accesses. There are other ways to get accesses much safely to do these kind of cases. Aorta bifems, definitely try to avoid them. Very high risk of thrombosis. Again, fem-fem bypasses on the third picture, definitely try to avoid it. Pedal access. Yes, you can do pedal accesses on any patient you want, but my reservation is, I would say, if you do a lot of things which are very unlikely to be done in a hospital, that's when people will start talking about your OBL. Right? It's like you're doing stuff which are not usually done in the hospital. Do it exactly like you do it in the hospital, like you were trained to do. I always use femoral access unless it's rarely necessary for patients. But like this patient has one vessel runoff, going primarily pedal access for this patient. With this vessel, especially here, is like probably 2.5 vessel. It's severely diseased. Putting a pedal sheath on this in this first patient is probably not the right thing to do for the patient. It's the wrong thing to do. Would you have done it in the hospital? No. Even if it's in the hospital, you should not be doing it. Especially if the patients are claudicants. And this patient again has plantar articulation. There is a graft here probably which is coming out of the plantar posterior tibial artery and forming the arch. Sticking this posterior tibial artery and trying to reconstitute it is probably not the right thing to do. Right patient for you. Any patient can be performed in the outpatient interventional suite as long as you are comfortable with it and if you think the patient is not going to go through any inconvenience. Clinical judgment is the key. You have to use the clinical judgment. Is there any risk of any possible complications? Case should be avoided as much as possible. You always have hospitals to take care of this. Be ready for surprises. No matter how good you are, there's going to be a surprise. So just keep your backups ready, and I think Dr. Abu Faris is going to talk about the complications and everything. He's going to tell what you should definitely have in the patient labs as a backup. Venous cases. All the venous cases can be safely done in the OBL. No matter how complicated they can be, but some things should be avoided only because it takes more time and it puts you at a very high risk. High thrombus burden cases, absolutely. Multi-level thrombosis involvement, yes. I think not that we cannot do it, I think it's the matter of time. Dual IVC cases definitely should be avoided because if you do it in OBL, you're going to miss, I'm pretty sure you're going to miss a lot of dual IVC cases, which is 5% rates of dual IVCs, so you're going to miss it. Aberrant iliac vein cases, you're going to miss it because you're going to be in a vein, iliac vein, which you think it's an iliac vein, and you start ballooning them, they're going to have back pain. Now you're stuck. Yes, they can have bleeds, but they are venous bleeds. But these venous bleeds sometimes can be very, very, very profuse. Iliac vein cases, especially with an IVC filter, should be avoided only because you need a lot more equipment to take care of this, which is probably not worth it in the OBL. Dialysis patients, most of the dialysis patients can be done in the hospital. Actually, dialysis probably graft interventions are probably the right thing to do in the office. But again, if you have significant subclavian clot burden, not the right thing to do. History of prior pulmonary embolism, definitely try to avoid it. There's no reason to take a chance because patient goes home. Because the patient is coming to you for dialysis, opening the dialysis graft, you declot it. Next day he's getting dialysis and he has a PE. Trust me, you don't want that. You're getting a call from the dialysis center, it's not worth it. Patient with newer anticoagulations on board, yes, they're going to bleed a lot. So patient is going to be there for a long time. Can you do it? Yes, you can, but it's not necessary. Prior Steele syndrome patients, definitely avoid it. Alternate access, radial case, definitely avoid. You can now, a lot of people are doing primary radial interventions because some Terumo has come up with great radial kits. So definitely, I think it's R2P equipment, which is great. Can be done. So a lot of people primarily do it. Again, it depends on, you should definitely try to avoid prior CVA patients, especially if you're doing right radial, definitely avoiding stroke patients. You just don't want, there's no reason to take the chance. Subclavian disease patients, definitely avoid it. Lima patients, yes, don't put a 6 French sheath through a Lima. It's not wrong to do it. You can do it, but you don't know how long your peripheral case is going to take. If you end up with any complication, your sheath is going to stay there for a long time. There's no reason to put a 6 French long sheath through a Lima. You don't even know if you're kinking your subclavian. You don't know the tortuosity in the subclavian. You don't want the Lima flow to go down and for him to end up having a cardiac ischemia. Antegrade access, avoid in obese patients for sure, and calcified vessels. Popliteal access, if it's a one vessel runoff, no popliteal access. Less than 5 millimeter vessel, definitely no popliteal access. All right. Direct SFA access, try to avoid it as much as possible, but if you're doing it, you should always have a covered stent ready in your office. Most of the times you can get away with a blood pressure cuff, like Dr. Asher was telling, but again, just keep it. You never know which, once you open up the vessels, they might be really difficult to close. Direct stent access, they should definitely try to avoid it. Makes it more complicated to do it. Can you do it? Yes.